Please take your seats. The meeting is about to begin.
All right, welcome everyone. Thank you so much for joining us today. My name is Laura Helmuth. I'm the editor-in-chief of Scientific American magazine, and I'll be moderating the panel today. The panel is brought to us by Springer Nature in partnership with Takeda, and we have registrants from 86 countries, actually more than 86 countries, I think, and counting. So thank you so much, everyone, for joining us from around the world. Thank you to those of you who are watching from the future, who are in different time zones. You know, health equity is a global issue, and it's something we hope we can help people from around the world learn from one another, inspire one another, and so we're really delighted to see this interest from everywhere. So to start us off, I am honored to introduce you to Charlotte Owens, who is the Vice President and the head of the Center for Health Equity and Patient Affairs at Takeda.
Thanks so much, Laura. And again, I extend my welcome to everyone who's able to join us. Good morning, good afternoon, good evening to everyone who's joining us in the room and also virtually. My name, as you heard, is Charlotte Owens, and I have the pleasure of serving as the Vice President and head of the Takeda Center for Health Equity and Patient Affairs. Takeda is a global value-based R&D organization that has been steadfast in its commitment to patients for more than 240 years. And it is because of our deep roots and our mission that we recognize that meaningful change can start at the corporate level, and that more and more these days we have a responsibility bigger than ever to create the world that we want to leave for generations to come. At Takeda, we're committed to partnering with patients, advocacy organizations, caregivers, and families to provide the access that they need to the medicines and the therapies that they need when they need it to live better, healthier lives, no matter where they live, where they're born, where they work, where they play, where they age. The Takeda Center for Health Equity and Patient Affairs was launched in 2020. Our team collaborates internally and externally with diverse partners, including patients, communities, and organizations, to identify and address health inequities in communities, not by our own knowledge, but by co-creating, listening, learning, sharing, and partnering like we are with you today. With more than 25 years of experience in pharma and academia and as a practicing OBGYN, I can tell you that finding the solutions to advance health equity are too big for one entity to solve. And that's why in the spirit of our mega community thought partnership across sectors that we've partnered with you, Springer Nature, one of the world's most trusted providers of scientific information for over 175 years, to help more people understand what health inequities are and to empower and to inspire them to not only listen and learn and co-create with us, but to be the change that they want to see in their communities. Health equity is a worldwide issue for everyone and everywhere, but what we want to do is to create the world where it actually exists, so that everyone, no matter where they're born, where they live, where they work, where they grow, where they age, have what they need to live their healthiest lives. This is what we must strive for. It's critical that we hold forums like today and have open dialogues like today so that we can share our experiences, our learnings, what hasn't worked, and most importantly, to try to create solutions that make the world a healthier place together. We've been working with you all for not quite a year, but it's coming up on a year, and I'm really proud of what we've accomplished, but most importantly, what's to come. Before we get into the panel, I am so pleased to introduce Takeda's Executive Vice President and Chief Medical Officer, Dr. Wolfram Nothav, who will share more about Takeda, our longstanding commitment to bringing better health and a brighter future to all. Now a few words from Wolfram.
All right, well, thank you, Charlotte, and thank you all for joining us today. I'm really grateful for the opportunity to be part of this special event that will discuss one of the most pressing challenges that impacts every industry, every person, and every community around the world: health inequities. Since the inception of Takeda more than 240 years ago, we've asked ourselves one question: what more can we do for our patients? I'm really proud to work at Takeda and lead the global medical organization, which also includes the Center of Health Equity and Patient Affairs under the excellent and outstanding leadership of Charlotte, because no matter what's happening in the world around us, we continue to ask ourselves the same question and validate guide who we are and the work we do on a daily basis. Our company is committed to engaging with patients and our partners, guided by our core values, integrity, fairness, honesty, and perseverance, which are actually brought to life through actions based on our 4 core principles. Putting the patient first, building trust with society, reinforcing our reputation, and developing a sustainable business, in that specific order. At Takeda, we know that in order to achieve equity, when everyone is treated fairly according to their needs, we have to start with this common understanding. That's why we're doing everything we can on a daily basis to better understand who our patients are and what they really need, so that we can create a more inclusive environment and practices and develop innovative medicines that allow patients to achieve the highest level of health in an actually equitable fashion. We are making good progress at Takeda and as an industry as a whole, but there's so much more we need to do. We can only achieve this in close collaboration, internally and externally, and that's why I'm actually so excited about this partnership with Springer Nature. When you actually go to their website and read about the Sustainable Development Goals program, you can clearly see why we are so closely aligned in our efforts to achieve health equity around the world. I'm also very impressed and encouraged by the incredible diversity and background of the so many attendees we have today. This is the collective effort we need to see, and I'm really grateful for all your support and commitment to achieving health equity. So a big thank you to all of you. As Charlotte reminded us, health equity, a world where everyone, everywhere has the resources they need to be their best, healthiest selves, is something we need to strive for. This is really requiring everyone's cooperation and commitment. So let's continue to connect, let's continue to collaborate, and let's continue to be the change we need to see to achieve this. With that, I'd like to hand it back to the folks in Boston. I'm really looking forward to the discussion we are going to have. Thank you very much.
Great, thank you so much, Wolfram. We have a lot to talk about today. Just to outline what our goals are, the panelists who will join us shortly, we're going to talk about defining the problem, kind of understanding what is health equity, discuss solutions, and also talk about future directions. And we're also here to answer your questions. So if you're in the audience, please at any time, go ahead and submit your questions through the Sligo, the program that you're on. We'll answer them at the question. We're reserving some time to make sure we get to the things you want to talk about. And also, this event is going to be part of an ongoing conversation. So at the very end of the panel discussion, we have a couple of announcements about additional opportunities where we can all continue to work together to talk about health equity and try to advance health equity approaches. So next, I'd like to introduce Magdalena Skipper. She is the editor-in-chief of Nature, and she'll be joining us by video.
Hello, and thank you for giving me the opportunity to contribute to this interesting and important meeting between Springer Nature and Takeda. Equity and inclusion lie at the core of our editorial practice across the Nature portfolio, and this means right across all research disciplines. Among them, advancing equity in health and medical research and practice is quite likely uncontroversially the most urgent. Diagnosis, prognosis, and treatment, as well as access to healthcare, are all affected in various measures by genetic ancestry, sex and gender, social, cultural, and/or physical characteristics, as well as previous environmental exposure. And yet we know that, for example, individuals enrolled in clinical trials are in general not representative of the patient population at large. Exclusion of women from clinical trials for many decades and its consequences are very well documented, of course. Inequity is tragically widespread. When it comes to healthcare, COVID-19 has made us even more aware of the scale of the problem. Back in June, we wrote in a Nature editorial, one of the first things that researchers can do is to ensure that their work is not contributing to outstanding social inequalities. Health interventions, ranging from COVID-19 vaccines or drugs to new technologies, can improve overall public health, but if they reach people in rich countries or people who already have access to high quality healthcare before those who have fewer advantages, they will also contribute to inequality. We, the editors and publishers, have ample opportunity to contribute to advancing health equity. We can do so by promoting and in fact seeking out biomedical and clinical research that is inclusive and equitable. This means showcasing work that is inclusive of underrepresented researchers, medical practitioners or participants. It means showcasing work that emphasizes co-creation or co-design, that is designed to appropriately share study results and promotes benefits to all. We can also make a difference through our editorial policies and frameworks. This spring, we announced 2 such initiatives. First, we started prompting our authors to provide details on how sex and gender were considered in study design. We wrote in an editorial, by introducing these changes, we aim to promote transparency in study design and ultimately make findings more accurate. And over time, we hope to see integration of sex and gender analysis in study design by default. Later in the same month, we announced a new framework to improve inclusion and ethics in global research collaborations, amid wider efforts to end exploitative practices. Our goal here is to safeguard against so-called helicopter research and ethics dumping. We recognize that to truly enable health equity, the entire research and medical community in public and private sectors need to join forces. The existing efforts need to be rewarded and recognized. And this is an opportunity for us all. And together, we will be more successful. Thank you.
Great. Thanks so much to Magdalena. And our panelists have joined us on the stage. So we're going to have a couple different conversations that will build on one another. We're going to start by hearing from Charlotte and 3 of the chief editors of 3 Nature journals who are particularly focused on health equity. And can I ask you 3 to introduce yourselves to the audience, please?
Yes, of course. I'm Alexia Elena Zaramitidou. I'm the chief editor of Nature Cancer. And cancer being a huge global health issue, but also an issue that is hugely affected by health inequities, this is a very important conversation for us to be having today to start understanding what defines these inequities better and how to address them to improve outcomes worldwide.
Yeah, my name is Akin Jimo. I'm the chief editor for Nature Africa. Nature Africa is one of the key platforms that Springer Nature has created to address researches in sub-Saharan Africa. We have Nature Middle East. We have a number of other platforms, Nature India, to address key issues in the countries in the South, in developing countries, in a way that efforts of researchers in developing countries can be brought, to the public limelight and then be a peer, with the global North.
I'm Rebecca Cooney. I'm the chief editor of Nature Mental Health, which is launching in January of 2023. And as a new journal and also sort of a new area for Nature to expand its reach in sort of publishing the best research out there, we're really hoping to provide a new space that takes away the silos of things like public health and psychology and psychiatry and provides a forum to discuss those side by side, and then also to really elevate diversity and the representation of various aspects, including across the lifespan and gender research and lower and middle income countries alongside high income countries. So it's very exciting for us to be part of this conversation as well and to help move this forward.
Wonderful. Thank you so much. So to start us out, I have kind of a foundational question, I think, for Charlotte and then Alexia, which is, how do you define health equity?
Well, I think, one of the things that we want to achieve with when we reach health equity, it's a goal, is where everyone has what they need in order to reach their healthiest potential in life. And what that specifically means is recognizing that not everyone needs the same. That what we are truly trying to get to is the concept of personalized medicine, where I get what I need in order to be my best version of health, and so does Alexia, and so do you. And I think that's what we're really striving to achieve, but not just do it intermittently by thinking about health care in and of itself, but thinking about the social determinants of health, which really drive most of what makes us healthy.
Yes, I will echo what Charlotte said. It's essentially providing equitable opportunities to everyone to achieve health, and that means achieving a tailored approach that takes into account people's needs, their circumstances, where they live, what they're facing. And I think it's also important to make the distinction between health equity and health equality. Health equality means leveling the playing field and trying to provide the same opportunities to everyone. So for example, maybe in cancer, it would be the opening of a lung cancer screening center in a city where people can go and get screened. Health equity means looking at what each individual needs and catering to that. So for example, in terms of health equity, it would be deploying lung cancer screening units to the areas where people need them the most because, for example, they live in polluted areas and they have a higher risk of lung cancer. So I think it is important to keep the two terms in mind.
Great, thank you so much. And then a question for all of the panelists of this segment.
Yeah.
You all have slightly different areas of expertise. What are some of the big health inequities that you see in your area, and what sort of impact are they having globally? And I know we could talk for an hour about each of your areas of expertise, but just some highlights for the audience so that they know where you're coming from.
Yeah, when you look at us as humans, fingers are not equal. It's very obvious. But what we need, we have a lot of commonalities. But where we are coming from, there's a saying in my language that what is behind 6 is more than 7. So you have quite a number of others. So what makes a man are a lot of factors all around. Sometimes you see a pregnant woman in my environment. You don't know if that woman is going to be part of the 6 that will die within that hour. Those are challenges. And when you see all those things, you realize that there are the same commonalities amongst all of us. And when you see those things, you realize that, wow, what do we do about it? There are a number of other infectious diseases that are booting. COVID-19 is not going to be the last. When it came, we are all running up and down. There was no understanding anywhere. We have to do the best we can. And when you see those challenges, you realize that, wow, what happens in faraway China or in the US, or what happened in Africa or in Latin America, everywhere, it can come here at any point in time. And those are the dynamics that we need to really look at, that we are one at any point in time, and we have to do everything we can to address our issues. Because it is when I say our issues, it's everybody's issues. Those listening, those who are here, wherever you may be. Location may be different, but there are a lot of similarities in the challenges that we have.
Thank you.
I think expanding that a bit to the idea of looking at an individual and crafting interventions in order to improve the outcomes of a disease state, for example, we have to consider that we cannot simply treat someone and have their circumstances stay the same. And so I think that we need to also consider health inequities as these very mundane, prosaic things. They could be very extreme circumstances like not having electricity, but they could also be not having coverage that supports a particular provider, or not having access to essential life-saving medications. And so there's a reciprocity to it, and if we don't look at the health inequities and really understand what those are, it's impossible to move people toward a path of health equity.
And building a little bit on what Akin and Beck just said, taking cancer as an example. So cancer is a global health issue. 1 in 6 deaths worldwide occur because of cancer. And it is really a disease of inequities and disparities. So for example, 70% of these deaths occur in low and middle income countries. And although we nowadays have very advanced treatment options. 15% of low and middle income countries have such options. So you can see the very stark difference when it comes to economic status. But this is not where it ends, because cancer inequities are also very visible at the local level, within countries, within cities, within neighborhoods. As an example, taking the United States, high-income country with arguably one of the best health systems worldwide, or oncology systems, let's say. There is a huge difference on whether you live in a rural or urban area in terms of what type of oncology care you're going to receive. Actually, 10% of oncologists in the United States are concentrated in 3 urban areas. 66% of rural counties in the United States do not have an oncologist. So even if you have an acceptable, good economic status, if you live in those areas, you will not have access to healthcare. And added to that, Charlotte mentioned the social determinants of health more broadly. We have issues in different countries to different extents that have to do with discrimination, racism, with poverty, with the environmental conditions in which we live. So the problem is extremely complex. And when discussing it, it's important to consider all these different aspects and how they intermesh. And this is the only way to actually find some workable solutions.
Nice, thanks.
And I think even when you identify the what and the where the inequities lie, finding a way to help people not only seek the care, but to continuously have access to the care in a culturally competent manner is complex. Because even if some patients that I sometimes see in the hospital, if you identify an inequity, the ability for them to want to receive assistance is another potential barrier based on their experiences. And so we have to go beyond just the identification of the what and the where to understand the why, which is one of my favorite questions, because then you can provide an action that is uniquely tailored to the patient. And one might think, if you're in the service industry, that this is not your issue, or if you're in a environmental industry, this is not your issue. But the one thing that we all know is without health, we cannot be a strong community. We cannot have what we need for our families. And there's a recent study that shows that improving one's health provides as much economic benefit to us personally as education. So the connections are what we have to make sure people see between the built environment and everything that moves us away and towards health. That's a big challenge.
Nice. Akin, could you talk about what are some of the biggest challenges that you see to achieving health equity?
Well, one key thing we need to understand is the fact that, at any point in time, we have rights. But there's no right without responsibility. Government has a responsibility. Individuals also has a responsibility, because there's a saying also that if your neighbor is doing bad thing, when the crisis comes, you won't sleep. As your neighbor doesn't sleep, you also won't sleep. So government has responsibility to us. There has to be a commonality in terms of what are the things that I need to do to have that equity, to have that access, to have that care. And government needs to provide programs. People pay taxes and so on and so forth. If you don't pay your tax, how do we provide, those facilities? So there's really no right without responsibility. So it's a collective. It's not just, you just put everything in one silos. Everybody needs to put in, what, they need to do. There are programs globally. You think globally, but you have to act locally. There are a lot of treaties and all the other things that were done at the UN level and so on and so forth, at the African Union level, at in Asia and so on and so forth. What happens? Recently there was an initiative by the African Development Bank, to address African Pharmaceutical Foundation, to address key issues when it comes to vaccines and so on and so forth. Those are initiatives, but how do we take it, to the last mile? And those are where our responsibility lies.
Nice, thank you. And then Beck, to wrap up this part of the conversation, could you tell us a little bit about what some of the health equity issues are in research that you're seeing that we're trying to address now?
Yeah, I think there's sort of two different buckets. Magdalena pointed to a lot of the efforts that Nature has in particular put towards, for example, disaggregating sex and gender data. We want to have more granular data that is better representative of, disease states across every sort of disease burden that we've got. But also, I think, to Charlotte's point of the why is that, in addition to building capacity for research and infrastructure, we also need to be a lot more creative about intervention. So for mental health, it's decades of neurobiological and psychological research. But there is also a shift now to including inequity-based interventions. So how do we go much further upstream and look at, say, job skills training? So if somebody is schizophrenic and it has difficulties with, relating to others, finding employment that's meaningful, can we move that intervention up further so that we're helping people through either universal basic income or other sort of skills training, and then looking at how the outcomes respond to that. So it's really a complete and more holistic framework, I think, for research. And that's very exciting. There will be a lot of interesting work that comes out from looking at a different part of the chain.
That's great, thank you. So we're going to pivot now to talk a little bit about some specific real-world solutions for advancing health equity. And this discussion is kind of a continuation of it's a long-term partnership between Springer Nature, Scientific American, Takeda, and one of part of the inspiration for this part of the conversation comes from a package that we published in Scientific American called Innovations in Health Equity, which came in the June issue of Scientific American, and with support from Takeda. And as part of the package, Takeda highlighted the work of Robert Paulino Ramirez in the Dominican Republic. So he's here with us today. Thank you for joining us. And he works with an organization called Seeding Labs, and the CEO is with us on the table, on the panel. Could you both just introduce yourselves briefly before we really dive in?
Thank you so much. I really appreciate the opportunity of being here with you and the people that are attending the meeting from abroad and in many countries around the world. I'm Robert Paulino Ramirez from the Dominican Republic. I'm the principal investigator for the Institute of Tropical Medicine and Global Health in Santo Domingo, the Dominican Republic.
Hi, I'm Melissa Wu. I'm the CEO of Seeding Labs for a nonprofit organization, and it's our goal to support international development by making sure that it's led by scientists from every country. And so our role, we supported Dr. Paulino in establishing their Center of Research.
Great, thank you. And we're going to be sending you more information. Everybody who registered for this event, we'll send you an email at the end with a lot of information about this package that was in Scientific American, with some other collections of journalism around health equity. We'll have some announcements at the end about additional opportunities. And also just a reminder, if you have questions for anybody on the panel, please go ahead and type them in now. You don't have to wait for the end. We'll get to the questions at the end of the hour, but feel free to send them anytime. But now to kind of start with Robert, can you tell us a bit more about your work and how you're working towards health equity in your position?
Yeah, well, trying to delineate a model of implementation for our institute and understanding the specific needs that are confronting the different communities. Sometimes it's necessary to go back into the books and identifying what the experts around the globe are trying to delineate what is necessary. And it's one of the biggest challenges that we are having in global health right now, to understand how we can reduce that gap that historically we has been confronting in many countries in the global south. So trying to approximate that, the WHO Commission Aid for the Social Determinants, we're delineating the three most important elements to identify and to tackle. The first one, improving the access to an equal perspective. Second, to tackle the differences within the distribution of money, resources. That is very important. And we're going to go back into that because that was fundamental from our relationship with Sitting Lab. And finally, to identify and measure the problem. So the three axes that are confronting that are permanent to understand are having in the center the communities, the user of our healthcare system, and then the academia, the relationship with the government and agencies and NGOs as well that are collaborating into reframing that distribution. And finally, the community, the voices of those communities, trying to understand them. So our approach was identifying the most important problems that were affecting the Dominican Republic at one particular moment. And it was definitely infectious diseases. We are hit by so much infectious diseases that are bacterialized by mosquitoes. That was previously, obviously, COVID-19 in 2017, when we already experienced an outbreak of chikungunya and Zika. So we were having a lack of a space to make a response and to address those problems and to better understand what was the better way to understand how to tackle those problems. So we were lacking that as infrastructure. We were lacking the equipment to do that in a more precise way. So we tried to identify the resources to do that, and then Sitting Lab was coming into the scene, facilitating and to reducing that previous gap that was pertinent to the local research infrastructure. The Dominican Republic, as many countries in Latin America, are experiencing that kind of problems. We have many different problems, but at the end of the day, the government is not providing enough resources, or we are not having actually enough resources to invest on first world equipment or molecular techniques to identify, for example, in an epidemiological surveillance, molecular surveillance, early on health threats. So I think that's one of the first example. Probably Melissa can elaborate a little bit further on that initial approach. And we have many other examples definitely after COVID-19 was coming up, many other things that we can discuss further.
Thanks. Well, it's really fantastic to kind of be able to bring together a lot of the things that have said in terms of real world examples. Charlotte was talking about very personalized experiences, and that's one of the things that I think is important about health, that it's always changing, and thinking about who is involved, as Akin said. And us, I think a lot of us here are researchers, and understanding the importance of the whole system that supports health and the importance of research, the academic space, and being able to address those changes in health that are happening all the time due to all the different challenges that we have to us. And so, I think for us, we see a lot of the academic and the research space. That's where we invest our resources in being able to be more geographically spread out. And so they're reaching more local contexts and also growing in their role in advocating with the government, advocating with their local communities, and educating for change. So for example, the coronavirus pandemic pushed a lot of things, but we saw in a number of the countries that we work with, in Uganda, in Ghana, just like in the US, most of the resources are concentrated in the capital cities. And so the universities are spread out all across the country, and they're able to add support to the health systems for diagnostics. And that was actually a new thing. But being able to see that we can reach greater equity by having this greater distribution, these local contexts, like Robert, who's very embedded in his local community. I think that's what we're seeing, putting all of these pieces together and really supporting the locally led research.
Yeah.
And could you tell us a little bit more about how, how you jumped into action at the beginning of, one of many pandemics?
When Melissa was describing a little bit the experience on the COVID-19 emergency, and I remember that in our country we were confronting such a big challenge on testing and diagnosis, and the majority of people that were lacking a diagnosis at that moment were people in the public system. So the private sector, many people can afford it, so they are just, so the inequality gap that was created during the first month of the pandemic in the DR were really serious. So we were trying to tackle down that, to identify how we can help on that. And so as a research-based department, it was a challenge to move on all our efforts into one single way that was providing the diagnosis. So at the beginning, it was really challenging to set up everything in a very short period of time because we were having so much pressure from the community. But then having the opportunity of receiving those coolers full of samples from across the country, from the public hospitals, that was providing so much responsibility, and at the end of the day, a big reward, because we were actually answering to the people most at need. We were receiving calls from the hospital directors telling us, I have a patient that is on the delivery that is waiting for that result. We really want to know if she's at risk or not, because at that specific moment, we didn't have vaccines yet. And then having the light at the end of having access to vaccination was something that was also facilitating our involvement into that. Our efforts then were redirected not only to the diagnosis side, but also working at the community for helping and assisting the government into the vaccine distribution in a more rapid and deployment. So these kind of elements are refreshing our minds into what was happening in the 80s and the 90s when the HIV pandemic was hitting most of our countries, that we were not having any tools for diagnosis, nor physicians were not even having medications for that. Now we are having the access for this, and also preventive care and preventive tools to reduce that possibility of newly infections. But still, and I think that's what happens with the healthcare system. Healthcare system is a marvelous place to create a stigma and inequalities as well. So we need to be very cautious about how we are approaching communities and how we are identifying the risk and describing the risk to the communities, to the public speaking, because the communication in science is so important. At the end of the day, everything that we are saying gonna have a positive or a negative impact. So we be very cautious, because at the end of the day, involuntarily, we can create those inequalities as well. That was even happening very recently with the monkeypox outbreak in many of our countries. The question was, we should say that it's homosexuals and gays that are being only affected. And then, no, let's sit down. We have a very good history to take back the AIDS history. Then in order to reduce all of those stigmas that were created at the very beginning, that are still with us today, the communication with the community is essential. So it's not only being sitting down here as academic, having a good theory, but how we are transferring that into what people can understand.
Yeah, thank you. Yeah, it's such an important reminder for everybody in the audience in our 86 countries plus to hear that advice. And Melissa, so you work in a lot of different countries. Should people in the audience be contacting you if they want to start partnerships?
Oh, yes, absolutely. Okay. You can go to our website, seedinglabs.org. Thanks for that little blurb, and learn a lot about the different kind of work that we're doing, investing in LMIC-led research.
Great. Excellent, thank you. So I think we're going to open it up now to the whole panel again to talk about the future. And you know, there's a lot of ways forward. So for all of the panelists, kind of an orienting question, from your perspective, what needs to happen to advance health equity? And as part of that, if it's part of your answer, how can people in the audience participate in those efforts? And if it's all right, we'll kind of just go in this order now.
You know, I think to start down the path of health equity, it starts with the understanding. Health equity is not an optional side thing. It is something that you actually have to incorporate in how you see the world, how you think. And you have to move beyond theory into action. It's, for me, one of those things where you just have to ask yourselves, is the solution or the product or the way I do my work reaching as many people as it can, because I've considered how people will touch my work very differently based on where they're starting from. And that's what's really key. It is important to first understand that. And so we have to then seek to understand what the issues are, not just the what and the where, but the why. Right. And then we have to listen to the community and co-create potential solutions to the problem. But then recognize that this is a multifactorial issue, meaning that there's many layers, and if you go 4 blocks, the issues may look the same, but they are probably drastically different, and so you have to bring partners. This is too big for one person to solve, but you shouldn't be dismayed by the enormity of the problem. Instead, you should use that as fuel beneath your wings to try to make sure that you are striving to do what children do as they learn to walk. They first start to move a little awkwardly, and then they learn to roll over, and then they learn to stand up, and then they get steady in their gait, then they start to walk, and eventually they run. So the fact that walking is a big deal doesn't stop them from trying, and we have to remember that as we're trying to tackle the problem. Start where you can locally. Start with the things that you actually have control over, and then bring along friends. And then finally, remember, you want to try to create a sustainable solution, something that the future generations can build upon. So not to just think about what you can do today, but to think about the interconnected pieces, other people, the planet, and sustainability, so that when you're thinking about what you can do, that you're getting all these ideas so that you can try to make it a solution that others can be independently executing on, hopefully with that start. So,
oh, that's great. And if you trip, if you stumble, get up,
try
again,
and try again.
Nice, thank you.
Yeah, I will echo again what Charlotte said. We should not feel daunted by the enormity of the problem, but we should approach it in smaller, more manageable units. Focus on the local and see how that translates in a broader geographical region, for example, globally, and try to learn from different areas as well. For example, we can learn a lot for other diseases from what happened with the COVID-19 pandemic. And how, what were the issues we faced there in terms of the inequities that became very apparent, and how we addressed them, how we equalized, opportunities for people to get treatment. When it comes to cancer, it's essential to have a more localized approach to understand the what, the why, and then figure out ways to address it. For example, a huge proportion of cancer deaths are preventable if we can only identify these reasons and actually help people help themselves. When it comes to cancers that are caused from human papillomavirus, for example, we have had for many years vaccines that can prevent this disease, and yet the studies show that out of the millions of women who have been vaccinated worldwide, only 1% are in low and middle income countries. And that is where the majority of deaths occur because of these diseases. So we need to figure out the why, and all of us need to contribute, but we need to engage locally with the people on the ground in these communities. Coming to cancer again, I think there is a lot of discussion about on this topic, and a lot of positive energy and will to actually enable and enact change and not just stay on the surface. For example, yesterday, President Biden here in the United States, on the anniversary, the 60th anniversary of the Moonshot Initiative of the Kennedy administration, spoke again about his cancer Moonshot Initiative, his ambition to end cancer as we know it. The ambition is to limit cancer deaths by 50% in the next 25 years. And I think this is extremely inspiring for anyone working in this space. And it is very ambitious. To achieve it, one of the major things we need to work on are health inequities in cancer. And in a country like the United States, that includes financial toxicity of cancer care, access to health care. And I will finish with one thing. You asked what we can each do. We can each do our small bit in our community. People who are involved with healthcare in any way have their expertise to help in specific ways. People who are not involved directly in healthcare, they can get involved in their communities and figure out what are these social determinants of inequities that they could help address.
Nice, thank you. And that's a good reminder too, with HPV during the pandemic, with a lot of childhood or young adult vaccines, people naturally fell behind because it was a little bit risky to go to the doctor. So that's a good reminder that this is the time to catch up on HPV vaccine and all the other childhood and young adult vaccines. Thank you. Yeah, Akin.
Most of the things we are talking about are issues that have been spoken about before.
Yeah.
And there has been a lot of investment in healthcare. There has been a lot of funding from USAID, DFID, and so on and so forth. You come to address a problem as a project. Mm-hmm. When the project ends, the problem remains. Mm-hmm. The money is finished. And then another year, another design comes, the same thing, dressed in a different cloth, and then it ends. And how do we sustain key issues to address our needs? Polio was eradicated in Nigeria a few years ago, and now polio in other parts of the world. Monkeypox came, is now spreading. So if we sleep, something is happening elsewhere, and you don't do something about it, it will come to your doorstep. Mm-hmm. And there has to be a kind of a common purpose in a way that there's a buy-in globally. I flew 17, 18 hours to get here. You don't know where I'm coming from. You don't know what I carry. And the commonalities among us says that we need to do what we need to do in a way that I see you as, oh, this is my brother, this is my sister. And what affects you affects me. Tooling and retooling researchers is very necessary. The Center for Disease Control is now global. Virtually every country has a Center for Disease Control. There has to be collaboration. There has to be tools in a way that something is happening elsewhere. You already have people locally who can look at those issues just like what he's doing, and escalate it. This is what we've seen. These are because there are a lot of neglected tropical diseases, there are a lot of things that are happening locally that can, kind of jump from one area to the other. And these are some of the things that we need to do in a way that we can establish a system, that can be beneficial virtually to everybody.
I would just mention, echoing to this idea of the powerful force of stigma and preventing people from accessing care, and that can be in so many different settings, whether it's infectious diseases or mental health. We saw sort of the pandemic avalanche of opioid overdose deaths in the United States. And there is so much stigma attached still towards behavioral treatment and other interventions there. So how do we help normalize talking about health, and how do we normalize talking about our mental health really needs to be a priority, and that's something that we can all do in our daily lives, certainly. And I think also one sort of extension of that idea is, for mental health, the idea that we can have mental health parity alongside other forms of healthcare, and that has really lagged in this country, but is around the world in issues that just having access to care is not enough. It needs to be access to quality care. And so we need to start thinking specifically about, what the value is that we are bringing into interventions that, both in the global health arena as well as in higher income countries. So I'll pass that on to you.
Yeah. Yeah, but thinking while you were describing so many elements that you were confronting in different areas, one of the transversal elements that we need to pay attention to is the leadership. Who's leading the next generation? Are we including all those topics into how we are reconfiguring the academic discussions in our universities? And I have seen so many changes in many countries, but it's still in the global south, this conversation has not already started. So we need to start and speed up that because time approaches. So in order to reduce those gaps in reducing stigma associated to mental health, because it's going to be a big problem in the upcoming years, and also the emergence and re-emergence of infectious diseases that are going to be continuously happening in our countries. We need to understand how global is health right now. It was an initial concept. We were trying to reframe the concept a couple of years ago of global health, but global health is now. So we are living in the global health. So we need to include that transversally in how we are training our future doctors and healthcare providers as well. And also integrating their conversations, because still there is some hierarchy that happens in healthcare systems that are not allowing the psychologists to interact with physicians, physicians with nurses, and we're working in the same environment, right? So it plus clients, the users, people that are attending the clinic that has their own voice, that are not, that actually they are missing the conversation. Because for a certain reason in the last couple of years, that activation within the community in requesting and pushing on for many changes in the healthcare system has been lost. So we need to take back that conversation and including the possibility for having a more transversal and horizontal approach of health. That's probably something that will facilitate the future of how we are addressing the biggest inequalities in health.
And I think a lot about the system. And we talk a lot about how it's global health, but it has to be very community-based. And how do you unite those two ideas? And the reality is right now, Akin talked about how there's a lot of investment from USAID, from DFID, but 80% of the funding for research goes to just 10 countries in the world. So there's just a piddling of funding that is being, that is being applied towards establishing the infrastructure, establishing the health systems, establishing the whole society that you want to have in all of these local contexts. So if you're in a position where you are directing these resources, where you're benefiting from these resources, if you're doing research, for example, in cancer, your community may be here, but if you're looking at the health inequities within that system, can you be partnering with somebody who is working in a context that is where the population is being marginalized or neglected for some reason. So I think really taking a look globally at the resources and making an effort, no matter what part of the system you're in, but making an effort to really distribute that. That's how I look at what we all can do.
Yeah, thank you. And one more thing, if I may, I think communicating about what we're doing is so important. Right. Journalists, the media has a responsibility to help everybody understand what health equity is, what health inequities are, and especially to share solutions so that we can scale things that people are doing in local in local situations so that people in other local situations can learn from them, so that we can understand this is not an unfixable problem. There is no one solution. There are lots of solutions that we can try to explore together, try to share, try to export or import together. So this has been a great discussion. What's really stood out, like I say, there is hope. This is a really, health inequity is such an urgent problem. It's kind of the most stark and heartbreaking example of systemic bias, of inequality in the world. I mean, the fact that some people live, in different communities live longer or shorter than others. I mean, that's just most horrible, basic injustice. But it's something that we can all work to understand, to address, to find solutions to help people live their best and healthiest lives. And together we can encourage research that's relevant, that helps everybody do their work better, helps patients understand the situation, helps people advocate for themselves, help people navigate the healthcare system, advocate for better healthcare. And so I want to thank everybody for sharing all your knowledge and your support, everybody on the panel and the audience, again, currently, or if you're watching in the future, thank you for caring about this issue. Thank you for trying to advance health equity, for doing what you can and for helping others do what they can. And we have a couple of things to announce, ways you can continue to participate. The big announcement today is that Nature Awards, in partnership with Takeda, is introducing a new award. It's called the Inclusive Health Research Awards, to recognize and sort of amplify the work of people who are driving a more inclusive approach and really advancing health equity and promoting greater health equity globally. And this award is open to organizations, it's open to individuals anywhere in the world. We're going to send a link to everybody who's registered for this event so that you can find out more about it. But if for some reason you're seeing this and you haven't registered, you can search for it. I'm sure you can find the information. Applications are opening now. And please, nominate yourselves, but also nominate people who you know are doing good work and are maybe too busy doing that good work to nominate themselves. And sometimes it's hard to recognize how important you are personally, but the people around you can recognize it. So be thinking about that, like who can you suggest? And please share the information about the awards. This is something we're hoping word of mouth will get out in at least 86 countries. So we really want to hear about how people's work is advancing health equity. We want to recognize it. And there will be awards. There are 3 awards that will be given to some of the best entries of 20,000 euros each. So we hope that that's a little bit of an incentive to enter the award. The barrier is not high. It's a pretty simple award to enter. So it's not something where you have to send in a whole stack of 10-year qualification information. We just want to know what you're doing. And then we'll also continue more of this kind of conversation with what's called a Nature Cafe. And that'll happen on November 9th. And it'll be free. It'll be a virtual gathering called Advancing Health Equity Through Community Engagement. So we're going to bring together some leading scholars and activists and participants, providers of health equity researchers to talk about data and technology and especially grassroots engagement. So please join us for that if you can. And now we're going to pivot to the questions and answers. So I think Richard Hughes is going to provide some of the questions, and as we'll be answering these. But I just want to remind everybody in the audience that this is you can keep sending questions in, although I suspect we have too many to get to. But this will be an ongoing conversation. Bring your questions to the Nature Cafe. I think I can say contact any of us individually if you'd like to continue the conversation. All our bios are in the website for this event. And we want to, we're here because we care, because we want to hear from you, because we want to learn from you. And so thanks everybody for your attention. And now I'll turn it over for the Q&A.
Okay, thanks, Laura. We've had some great questions coming into the chat box, and it's too bad I don't have time to answer them all, but I've done my best to pick 3. And Laura, I'll let you direct these questions to the most appropriate panelists. But let's start with a question. Do you consider technology like AI and digital health approaches as a path to real solutions? Why or why not?
Oh, that's a good question. That might be something for some of the Nature editors. Do you have, is that something that you intersect with?
Oh yeah, absolutely. I think there is huge potential to harness machine learning, AI technologies. Over the last decade or more, 2 decades, we've been experiencing a data deluge in terms of all sorts of omics data. And just getting through these and understanding what they mean, integrating different data types and figuring out how to connect the purely genomic biological components with the why that Charlotte was talking about before is very important. So this is one space in which it can help. AI and computational approaches can also help provide new diagnostic means. For example, we can generate devices for cancer diagnosis, for example, or for monitoring patients and responses to treatment or post-treatment sort of events that might otherwise require them to go to hospital. And so there is a huge potential to get there. I will say that there is, again, this disconnect of those who have and those who have not. So when thinking of harnessing such technologies, it's extremely important to consider who the end user will be, or access to the most appropriate end user. In this case, end user being the patient who has the need. So when we're talking about bringing this to low and middle income countries, we need to be smart and devise ways to reach the people who actually have the need and might not have a smartphone, for example.
I think I totally agree with, location matters. Which place are we talking about? There are places, when I was working on polio, there are hard to reach communities. No vehicle, nothing. You have to trek. You have to go on bikes. And sometimes, vaccinators will sleep, in bushes and all the other things. So location matters. Yeah, it's something that is very necessary. That's why I talked about tooling and retooling in a way that, at any point in time, we have that tool, to do what needs to be done. There are a lot of areas of advancement already in terms of genomic mapping and all those things for COVID and so on and so forth. But the key thing is, after you've worked on the samples and the sample is taken elsewhere, you want to do other work, what happens? So all those things need to be taken into consideration. We are just starting more or less with that to a large extent. And what does the future hold? So we are introducing something we need to look beyond just now. What happens, with the next generation? Who are we mentoring to, carry on, the things that we are leaving behind, and so on and so forth? Because there's a time limit to life for everyone.
I would also say that one of the amazing things about some of the machine learning and especially computational modeling is that it not only is there a data deluge, but there's also an absolute data paucity around lots of mental health constructs, for examples, in regions where it's difficult to sample people or get people involved in clinical trials. And so we have used that, I think, tremendously to inform where we have these major gaps, and we'll continue to do so. I think that's probably one of the most exciting areas that can actually serve as a unifier among researchers from around the globe. And so it will also really be a useful way that we, help, augment human ways of doing things like systematic reviews and speeding that up. So I have lots of hope that we will continue to see that as a vital tool.
Great, thank you. Did anybody else want to say anything about machine learning, AI? Yeah, we can go to the next one then, I think.
Okay, next question. How can Springer and Takeda build a consensus with other organizations to ensure inequities remain part of the conversation?
Oh, good question. That might be something for Charlotte.
I think it's really about events like today, but also events that take place every day within communities, within your own conversations that you're having, within the understanding of how to think about caring for others through everything you do. And then recognizing that it's not enough for you to take care of your part of the world, but you must share it and find many different ways of sharing it. Share it by word of mouth, share it by written word, share it by social media, share it by transmitting it throughout different sectors within the organization. You know, we oftentimes really don't think about how you can deliver healthcare at the grocery store. But it's really important that you do. How can you deliver healthcare at the salon? But it's really important that you do. How can you deliver healthcare at the bus stop, on the subway? These are places where people are really highly engaged, and we sometimes, unfortunately, spend a lot of time in some of those places. But you're a captive audience, and most of the time, you're in such close proximity, you start to engage in a conversation. Oh, I love your dress. Oh, how are you doing? And then you build up a certain amount of credibility. Because again, the information in and of itself alone is not enough. Finding partners who are trustworthy and show themselves through action to be trustworthy is what's really key. And that's why we partner with patients, with advocacy groups, with private and not private organizations, with top publishing organizations like yourself, to not only have people that give us thought, but have people that have the ability to reach. And that's what happened today. And so we don't want to make this a mystery. Health equity is really not that hard to understand. It may be complex to solve for, but it is simply, what do you need to be healthy in and outside of healthcare? And transmitting that to others and helping others have a voice, and having others those like Robert and I who deliver care, making sure we're conscientious of that every time there's a patient in front of us. Making sure the nursing staff is conscientious about that. We are a company that is truly committed and have one purpose: to create better health for people and a brighter future for all. And so we're thinking about this constantly, and we invite everyone in every sector to do the same. So I think that's how we hope this partnership informs, inspires, and empowers people to do what they need to do.
Nice. Yeah, and one thing I think we've learned as we've been talking with one another and engaging with our audiences on lots of different platforms, on websites and social media, a lot of people care a lot about health equity and are trying to do their part. And I think it can be sort of empowering and inspiring to know that you are not alone. There are a lot of us who really care, a lot of people trying, experimenting with different approaches. And as you say, it's not complicated. These problems are solvable. We just have to have the willpower, the mutual support, the resources, the understanding, and partnerships are a really important part of that.
And one other thing is, don't look for the single answer.
Yeah.
There's not one solution.
Yep.
It's not a one-size-fits-all outfit, right? And because, even when you wear a one-size-fits-all outfit, it doesn't look the same on everybody. And so the solutions you try will not look the same on everyone. And be flexible. So it's not one message. It's not one solution. It's not one way. And it doesn't apply to one place. Just being comfortable with that level of ambiguity is inspiring for me. So we just have to be cognizant that this is not one thing.
Yeah, great, thank you. Do you have another one?
Well, this is a question which follows on quite nicely from what Charlotte was saying. Could the panelists provide one tangible thing each of us might do to help advance health equity in our own communities?
Nice. Meaning, and by us, do you think it means each of the panelists or the
I think it means all of us.
Everybody.
Everybody in the
Good
audience.
one. Okay.
What can we do to help in our small way?
Oh, nice. Should we go reverse order? Sorry.
Please.
You were safe there on the end.
I think, I'm a nonprofit, so I think you should look for organizations that are in the health equity space making a difference and see how you can engage with their work, whether it's donating, volunteering, doing board service. Find an organization doing what you're interested in and get involved.
I think that for those that are young people that are listening to us, every time that you are heading a project or a community, put your ears on earth and listen to what their voices are saying. instead of having a magical solution that is created in a lab, for example. I'm saying just a lab for a place, but trying to modeling the specific way to approach their community needs, and then work along with them and make that your flag, make that as part of your career, because that's gonna help many others to find a common ground solution for many of the biggest challenges that we are confronting this time.
I would say harness the moral and political will that is necessary to affect any of these changes. I think if you've dialed into this, then health equity for you is a moral function and something that is worthy of all of our invested efforts. And so find ways in your community to champion those causes and support others who champion those causes.
You know, to a large extent, information is in the hands of people who don't need it. And there has to be a form of public understanding of science. Science is the basis of quite a number of things. I mean, there's an element of science in everything we do. But do you understand that so that at a point of need, you'll be able to cross that Rubicon? And you find situations where people just need that information only. And we have all the facilities now, you know, everything, you can have information at your fingertip. Are we looking into that? Are we steering discussion in a way that people can also learn from us? Because the things you know, I may need, you may not need it. I may be the one that need that information. Why not provide it, you know, for me? When it comes to health equity, when it comes to you have a medical challenge and all the other things, second opinion matters. You know, I've seen a situation whereby someone came here for a medical procedure that would cost about $14,000 and realized that there are solutions back home. Went back home, spent less than $1,000, and the problem was solved because there was information on what to do. So we all need to equip ourselves in a way that we can have the requisite information at any point in time. Despite the attack on science, despite the attack on scientists, despite the attack on solutions, we saw all those things with politicians and all the other from the US to, you know, other countries, you know, during COVID-19 pandemic and so on and so forth. And it's like, are we sick? Those are things we need to ask ourselves. We need to do the needful, but you need to equip yourself so that you are talking from the position of knowledge, and then you can influence others.
I echo what was heard before, and I will say, as I said before, it's important to be active parts of our community, not passively exist within a community, but actually get to know what this community is about, who are the people who comprise it, and what the social determinants that bring in inequities in terms of health in that community are. It could be poverty, it could be lack of education, lack of health literacy, it could be lack of good quality food. These things are things in which we can all help. As I said before, we all just need to do our small bit in these communities. One example, a big example for all of us, is COVID. That came out of nowhere for the vast majority of people on this planet and locked many of us in our apartments. And then suddenly you realize how important community is. Some people couldn't leave their apartments to go and get groceries, and people in their community helped them. This is actually helping address a potential health inequity. So if we start thinking about it, not when we're having a panel here and we're participating actively in something to do with our work, but in our everyday life, and if we internalize that saying that health is not a commodity, but it's actually a human right, and accept this moral obligation, then I think we can do many things together.
Yeah, and I would just add to really understand that this is not someone else's problem, this is our problem to solve together, because we are all interconnected. Don't go alone, choose 2 or 3 friends to go along with you to figure out what small tangible things can you do where you work, where you live, where you play. and then pass the word on. Lead with kindness, lead with understanding that we're more similar than we're not, and that is the reason why you are doing for others what they need so that they can now be a part of a healthier community and we can all flourish together.
I think the summary of it is be your brother's keeper.
Yes.
Yeah, nice. Those are great answers. Thank you so much for these answers. Thanks to everyone in the audience for the work you're doing, for the concern you have, for your interest, for your advocacy for health equity. This isn't going to be over for a while. We've got a lot of work to do, but I hope this conversation has been inspirational. It certainly has been to me. Please encourage others, feel encouraged by us for the work that you're doing, and share information about next conversations, about the new award we announced, about any ideas, any successes you see. Especially, we really hope to learn from one another, be inspired, be supported by one another, and we're just grateful to everybody in this community, which is the community of basically everybody. We talk a lot about communities, but when it comes to health equity, it's everybody, it's the whole world. And so thanks for your attention. Thanks again to all the panelists, and it's really been wonderful talking with you today.
Yeah.